Hi guys, welcome everyone. I hope I'm audible and clear. So today we will be talking about the ECG changes in electrolyte abnormalities, and you all know that in last 3 or 4 years, almost every NEET PG and FMGE exam had some ECG related to electrolyte abnormalities. So after MI, AV blocks and arrhythmias, the next most important ECG topic for the exam going students is going to be the ECG changes in electrolyte abnormalities. Of course, you can have a simple table by heart the ECG changes for different electrolyte abnormalities and go to the examination hall and you should be able to answer the questions. But today we will try to understand the changes a little bit conceptually. Now, to be able to understand why we get this particular type of ECG changes in a particular electrolyte abnormality, we need to understand the cardiac action potentials. Okay. Now, cardiac action potential, when I use that word, we are referring to two structures. One, action potential of the SA node and the action potential of the ventricular myocardial cells. The action potential of the SA node, for now, I will keep it aside. We will discuss that when we go to the arrhythmias. Today, we will focus on the action potential of the ventricular myocardial cells. Okay. Now, we all know that most of our cells have some degree of voltage, and that voltage comes because the cell membrane, see, we have these cells and it has a membrane, and cell membrane separates the intracellular compartment from the extracellular compartment, and the composition of intracellular and extracellular fluid is not exactly same. For example, if I look at the extracellular compartment, it is loaded with sodium, chloride and calcium. On the other hand, when I look into the intracellular compartment inside the cells, the major cation is potassium, and there are plenty of anions like amino acids, right? The major anion in the extracellular compartment is chloride. The major negatively charged particle in the intracellular compartment is amino acids. The major cation in the intracellular compartment is potassium. The major cations in the extracellular are sodium, calcium, and to some extent magnesium. Okay. Now, when I look at the ventricular myocardial cells, of course, here also we have plenty of potassium inside the cells, usually 150 milliequivalents per liter. That is the concentration of potassium inside the cell. And we already know what is the concentration of potassium outside the cell, which is 5 milliequivalents or millimoles per liter. So there is a gradient, and this gradient creates the potential difference between intra and extracellular compartment, and this potential difference we are going to call it as the resting membrane potential. The main driver for this resting membrane potential is the gradient between the potassium concentration in intra and extracellular compartment. So when our ventricular myocardium is resting, it is not getting depolarized or repolarized, it is resting. At that point of time, the potential is going to be minus 90 millivolts. That is the resting membrane potential of the ventricular myocardial cell membrane. Okay. Now, from this resting potential, I can depolarize this ventricular myocardium and I can repolarize it back. Now, how do I depolarize it? The depolarization of the resting membrane potential or the ventricular myocardiocytes begins by the influx of sodium. So when the sodium channels will bring in the sodium molecules into the cell cell starts getting depolarized. This depolarization will increase the membrane potential higher, right? So from what was the resting membrane potential as 90 milliequivalents, minus 90 milliequivalents. This is where my resting membrane potential was there. Now, as the sodium starts coming in, the voltage of the membrane starts increasing. So now I will see a graph going upwards, So my membrane potential goes on increasing. It goes up to positive 30 millivolts, right? So this is the exact phase where we say ventricle is getting depolarized. This is because of the depolarization. So ventricular depolarization results in increase in the ventricular myocardial action potential, and this upstroke will reflect on the ECG as our QRS complexes, right? This upstroke will reflect as the QRS complexes. So this is where I'm going to get QRS complexes. And what is the reason for this? The reason for this buildup of the membrane potential is influx of sodium, right? Sodium is coming into the cardiac myocyte. Okay. After this we can call as, in the cardiac potential, we have different phases. We will call them as phase 0, phase 1, phase 2, phase 3 and phase 4. So this depolarization phase, we are going to call it as phase 0. So in phase 0, what is happening? In phase 0, there is influx of the sodium, right? So this is phase 0. In 0, sodium comes in and that causes the depolarization of the ventricular myocardiocite. Okay. After the depolarization, during this period, ventricle has contracted and done the ejection of the blood, right? That is what I'm seeing on the ECG as QRS complexes. So let me summarize the point again. Sodium entry into the cardiac myocytes of the ventricle increases the action potential. This is what we call as depolarization. With this increasing action potential, ventricle contracts, right? I see this on the ECG as the QRS complexes. With respect to cardiac cycle, this is about the ventricular systole. So ventricular systole, depolarization, sodium influx, QRS complexes all mean the same thing. Okay. After that, because we already know that we have high concentration of the potassium inside the cells, we will start some efflux of potassium. So potassium starts leaving the cells, potassium efflux. So with the potassium efflux, the potential drops a bit, and this phase we will call it as early repolarization. It comes back to 0. So this phase we will call it as phase 1. So we had phase 0, which is depolarization. Phase 1 we will call it as early repolarization. Phase 1 is early repolarization. Now this I will not be able to make out clearly on the ECG because this early repolarization is buried inside the QRS complexes. We don't see much happening on the ECG. Okay, but after this there will be continued efflux of potassium. So potassium keeps leaving the cell, but this gets kind of balanced by influx of, means potassium keeps leaving, but there is also influx of the calcium. Potassium is going out of the cell, calcium is coming into the cell, so there is a balance of the charged particles. Equal amount of potassium, equal amount of calcium are exchanged, resulting in no change in the membrane potential. So membrane potential will remain in this phase for some period. It will remain in this phase for some period. This is happening because, remember, phase 1 was because of the efflux of potassium. Phase 0 was because of influx of sodium. Potassium left, so potential dropped a bit. That we called as phase 1. Now potassium continues to leave the cell, but there is also influx of the calcium, right? So this phase we are going to call it as phase 2, right? This is also called as plateau phase. So phase 0 is the depolarization, then phase 1 is early repolarization, phase 2 is plateau phase. So here the membrane potential is constant, it is 0, it is not changing. This is exactly what reflects on the ECG as ST segment. So to summarize again, phase 0, right, reflects on the ECG as QRS complexes, right? QRS complexes, because phase 0 is depolarization phase. Then phase 2 reflects on the ECG as ST segment. This is the isoelectric line because there is nothing much happening. The membrane potential is constant. That's why in the ECG, neither I see an upstroke or a downstroke. It is remaining on the baseline. That's why ST segment. Okay. Now after this, we will have continued efflux of the potassium, and thus the potential decreases further. So there is continuous efflux of the potassium, and thus the membrane potential decreases further, coming to the baseline. This phase we are going to call it as phase 3. We will call it as either phase 3 or we can call it as late depolarization. And this late repolarization, this late repolarization will reflect on the ECG. Late repolarization will reflect on the ECG as T wave. Right, it will reflect on the ECG. Phase 3 is late repolarization. It will reflect on the ECG as the T wave. That's why we say T wave is the wave of ventricular repolarization. Actually, ventricular repolarization happens in two phases: early repolarization and delayed or late repolarization. Early repolarization, we don't see anything characteristic on the ECG, but late repolarization we see. Now my membrane potential has come back to its baseline, right? But once it has come back to baseline, I still need to maintain this potassium gradient to maintain the resting membrane potential of minus 90 milliequivalents. So for that, my sodium potassium ATPase keeps constantly working. So this we will call it as phase 4. Phase 4 is nothing but the resting membrane potential. Phase 4 is resting membrane potential. So now I enter phase 4, which is resting membrane potential, which on the ECG is going to reflect as the TP segment. TP segment, right? So on the ECG, that is going to be TP segment. That is the isoelectric line between T and P waves. And for me to maintain this potassium gradient here, the sodium potassium ATPase channel keeps working here. ATPase channel keeps working here. What it does, it brings, see, during this repolarization, I have pushed out a lot of potassium. So now I have more potassium in the extracellular compartment. Remember now, when I started this repolarization, I have pushed out a lot of potassium. So now I have plenty of potassium in the extracellular compartment and I have plenty of sodium. Sodium has all come into the intracellular compartment. So I need to push this sodium out and bring the potassium in. That is my phase 4. That is the resting membrane potential, right? So to summarize again, phase 0 is depolarization, which is because of influx of sodium into the cell. Then phase 1 is early repolarization, which is because of efflux of potassium. Then next thing is phase 2. So what is happening in phase 2? In phase 2, we are going to call it as the plateau phase. Plateau phase, which is because of the balance between efflux of potassium and matched influx of the calcium. And then I have phase 3. What is happening in phase 3? In phase 3, there is late repolarization, which is because of the efflux of potassium, right? So phase 3 is late repolarization. And then phase 4 is getting to maintain the resting membrane potential, basically balancing out the changes that we had caused. All the sodium that has been gotten into the cell and all the potassium that has been effluxed is now shuffled, right? So with the help of sodium potassium ATPase, I pump out the sodium and bring in the potassium so that I maintain this minus 90 millivolts as the resting membrane potential. Clear? So when it comes to the functioning of the cardiac myocytes, now we can clearly understand that the most important electrolytes are going to be calcium and potassium. Potassium is the single most important electrolyte, because for me to repolarize the ventricular myocardial cells, I need to keep pumping the potassium out, right? So if I have any abnormalities of calcium or potassium, I may not be able to carry out this normal depolarization and repolarization act of the ventricular myocardium, and that can reflect on the ECG. So with this backdrop, we will start understanding the ECG abnormalities in electrolyte imbalances, right? So let me quickly recap. First, we have resting membrane potential, that is phase 4, which is maintained by sodium potassium ATPase. So we keep effluxing the sodium and bringing in the potassium so that we maintain minus 90 millivolts resting membrane potential. And then whenever I have to contract the ventricle, I have to increase the membrane potential. This phase is the phase of depolarization, which is QRS complex from the ECG. We will call it as phase 0. This is because of the influx of sodium. As you see here, it is because of the influx of sodium. Okay, then we have early repolarization. Early repolarization is phase 1, which is because of the efflux of potassium, right? So I got sodium in and then I threw some potassium out. That caused a little bit of early repolarization. After that, we enter into a phase called phase 2. Phase 2 is where the influx of calcium matches the efflux of the potassium so that the membrane potential does not change. That gives me the ST segment. After that, we enter into phase 3. In phase 3, we continue to push out a lot of potassium, efflux of potassium, giving rise to late repolarization or phase 3, which is due to potassium efflux. That gives me the T wave, the classical wave of ventricular repolarization. Okay. Then I get TP segment till the next P wave. This is the isoelectric line where no major electrical activity happening. That is my resting membrane potential. Now, to maintain this resting membrane potential, whatever sodium that I had gotten in and whatever potassium that I had pushed out should now be exchanged. The potassium should come in and the sodium should be pumped out. So for that, sodium potassium ATPase pump is constantly acting to maintain the resting membrane potential. Clear? Okay. Now again, to be able to understand the ECG changes of electrolyte abnormality, because when we talk about calcium especially, we have to talk about, because where is the calcium coming into picture? Calcium is coming into picture in the plateau phase. So if there are calcium abnormalities, it is the plateau phase which gets affected. Either plateau phase becomes prolonged or it becomes shortened. For example, if there is more calcium in the extracellular compartment, the calcium will come into the cell much more quickly because there is higher concentration gradient, right? There are too many calcium molecules outside. So they will come in quickly because of the concentration gradient, and the plateau phase becomes shortened, right? And when plateau phase becomes shortened, what is it reflecting on the ECG? The phase 2 plateau is reflecting ST segment. So ST segment becomes shortened, right? Similarly, if the calcium is low in the extracellular compartment, then for me to achieve sufficient intracellular calcium levels, it takes longer time. So my plateau phase becomes prolonged. So in that case, my ST segment becomes prolonged. But as I've already told you in the previous ECG session, we generally do not measure the segment, we measure the intervals, right? So if I want to see in a particular patient whether ST segment is prolonged or shortened, rather I will see the interval, and which interval ST segment is included. It is included in QT interval, right? So in these electrolyte abnormalities, QT interval may get altered. So we'll understand what is QT interval, and then we will take up hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia. Okay. So what is QT interval? It is the interval which begins with the beginning of the QRS complex. That is the beginning of Q. If Q is not visible, the beginning of R wave, and ends with the end of T wave. So it includes QRS complexes, ST segment, and the T wave. Collectively, we will call it as QT interval. Now, if you ask me, sir, what is the normal QT interval? I do not have a straightforward answer. Why? Because whenever our heart rate increases or decreases, see, if my heart rate is increasing in this ECG, something has to be shortened, right? So what gets shortened? It is the QT interval that gets shortened. If my heart rate is decreasing, let us say sinus bradycardia, I'm in yogic trance mood and my heart rate is very low, in that case QT interval gets prolonged. So QT interval is influenced by heart rate. So whether there is true QT prolongation or true QT shortening, needs for that assessment, we need to correct the QT interval for the variation in the heart rate. So that's why we need to be aware of a formula called corrected QT interval, which is also called as QTC. QTC stands for corrected QT interval. Now, how do I measure it? There are so many formulas. Don't get confused between several formulas available on the internet. Most commonly, the one that we follow is Budget's formula. So I'm giving you the same formula here. What Budget's formula says is, whatever is the measured QT interval from the ECG, divide that by the square root of the RR interval. Square root of the RR interval, all expressed in seconds. QT interval is expressed in seconds. RR interval is expressed in seconds. So when we get this, we will get to know what is the corrected QT interval. Corrected for patients' heart rate by taking into account the RR interval. Now the normal corrected QT interval is 350 to 450 milliseconds for males and 360 to 460 milliseconds for females. So when it is less than 350 in a male or more than 440 in a male, we will call it as shortened or prolonged QT interval. Similarly, when it is less than 360 or more than 460 in a female, we will call it as shortened or prolonged QT interval. Clear? So next time you see a ECG, QT interval is not just a simple calculation. You have to actually measure the QT interval, and then you have to apply the Budget's formula by looking at the RR interval and using a calculator to calculate the square root of the RR interval, and then apply the Budget's formula and then come out with the corrected QT interval. Most of the modern ECGs will have the corrected QT interval mentioned. And because the corrected QT interval is mentioned in most of the modern ECGs, we really don't need to sit and calculate. But if you want to do this exercise, you can take any ECG, have a calculator by your side. For me, maths is difficult, so I will always need a calculator. Have a calculator, measure the QT interval, measure the RR interval, then calculate the square root of the RR interval, then apply the Budget's formula, you will get the corrected QT interval. Okay. So I hope we have the clarity now. So with this, we will start with the first electrolyte abnormality. And I will share the PDF on the Telegram. It's called PW MedEd notes, so where you can get it. Okay. First, we will start with the hypercalcemia. Okay. Now in this action potential, where calcium comes into picture? Calcium comes into picture only in the plateau phase or phase 2. Phase 2, right? So the funny current plays an important role in the action potential of SA node. Its role in the ventricular cell action potential is minimal. So the SA node's action potential we will discuss when we discuss the arrhythmias. Okay, so right now I'm concentrating on the action potential of ventricular myocardial cells. So when it comes to ventricular myocardial cells, calcium comes into picture in the plateau phase, right? So what is happening in the plateau phase? We are effluxing or pumping out the potassium and we are getting in the calcium, and both are matched, right? The quantity of positive charge lost and the quantity of positive charge gained is matched. That's why there is no change in the membrane potential. It remains constant. That is plateau phase or the ST segment in the ECG. Now, if I have higher concentration, we are talking about hyperkalemia, right? So I have more calcium in the extracellular compartment, right? I have a lot of calcium in the extracellular compartment. So then I will be able to achieve the desired concentration of the calcium in the intracellular compartment much early. Why? Because the rate of calcium movement from extra to intra depends on the concentration gradient. So if I have higher calcium outside and relatively lesser calcium inside, I will move much faster and fill the intracellular compartment quickly. So if blood calcium level increases, blood calcium level is my extracellular compartment, right? So when the blood calcium level increases, calcium in the extracellular compartment increases. So higher calcium in the extracellular compartment, relatively lower calcium in the intracellular creates a much wider gradient. So I will fill, or the influx of the calcium will become much faster. And thus this plateau phase gets shortened, because the plateau phase lasts as long as the loss of potassium is happening and the gain of calcium is happening at a rate. But if I gain the calcium much quicker, then equilibrium is established much quicker, and then I will not continue the plateau phase. I will get into the late repolarization phase. So there is a shortening of the plateau phase when there is increase in the extracellular calcium, or in simple words, blood calcium. So when I have hyperkalemia, what ECG change I am expecting? Increasing serum calcium leads to decrease in the duration of the plateau phase or phase 2. And with that, because plateau phase on the ECG is represented by the ST segment, there is decrease in the duration of ST segment. And as we know, ST segment is part of our QT interval, right? ST segment is part of the QT interval. So QT interval becomes shortened. So the first ECG finding that we are getting in hypercalcemia is short QT interval. Short QT interval. Okay. And if the calcium level increases severely, we get one more change, which is called as Osborn J waves. Osborn J waves. We'll understand what is this Osborn J wave. So first of all, in the ECG, we know what is J, right? There is a J point. What is J point? The end of QRS complex and beginning of ST segment. We call it as J point, right? The buildup of the calcium in the extracellular compartment now elevates this the J point, the end of S wave, higher, giving rise to a notched extra wave appearing on the ECG. We call this as J wave. So like if the QRS is going to look like this, the end of this S point, right? That's the end of the S point, and where the ST segment is supposed to begin, that is going to be my J point. That J point gets elevated, giving rise to a notch, and then I will have the ST segment. So this notched extra wave that came in picture, we call it as J wave or Osborn J wave. Okay, so we'll see both of those changes in the ECG. Let us first look at this ECG. In this ECG, what change I notice? If I apply the formula, I don't have the mathematical ability to apply the formula, but if I apply the formula, I can see that the QT interval is shortened. Short QTC, right? In these patients, we have short QTC. I will leave it to you, and the notes it will be available. You can calculate the QT interval, corrected QT interval, and then let me know how much it came. But this is clearly short. A quick look tells me that there is a short QT interval, because how much is the ST segment, right? ST segment is barely visible. There is shortening of the ST segment, right? And thus there is short QT interval. So there is short ST segment resulting in short QT interval. Okay. Now in the second ECG, you can see there is a small upstroke to the J point, right? You can see this Q, R comes down as S, and then S ends here. ST segment should start as the S ends, but then the J point is lifted above, giving rise to another wave, and then I have the ST segment, and then I have the T wave. So this wave is what we call as the Osborn J wave. Now this ECG is not actually of a patient with hypercalcemia. Hypercalcemia, Osborn J waves are rarely seen. It is seen in severe hypercalcemia. More commonly, this Osborn J wave is seen in patients with hypothermia. So this ECG is actually of a patient with hypothermia. So therefore, what is Osborn J wave? Raj Kingdom, RR interval refers to the duration between two sequential R waves, right? So this is one R wave, this is another R wave. The duration between these two refers to RR interval. QT interval refers to the duration between the beginning of the QRS complex and the end of T wave. This is QT interval, and this is the RR interval. So in the budget formula, we are taking the square root of RR interval and we are dividing QT interval with this square root value. Osborn J wave is a wave-like appearance of J point. So normally we have a J point, right? What is J point? The point where S ends and the ST segment begins, right? This point we will call it as J point. So where there is a slight notch, this notch is what we call as Osborn J wave, which is classically seen in patients with hypothermia, but can be seen in some patients with severe hypercalcemia. But if you ask me what is the main ECG change of hypercalcemia, it is the shortening of ST segment because of shortening of the plateau phase, resulting in a short QT interval, right? That's about hypercalcemia. Now what happens in hypocalcemia? Exactly opposite of it. So in hypocalcemia, there is decreased calcium in the extracellular compartment. So I will not be able to achieve the equilibrium between extra and intracellular compartment during the plateau phase early. It will take long time because I have less calcium. So there is slow entry of calcium into the cell. So plateau phase will remain in the plateau state for longer period, and then the late repolarization will start. So there is prolongation of the phase 2, that is plateau phase. So with the prolongation, ST segment become prolonged, and thus the QT, corrected QT interval will also become prolonged. So in hypercalcemia, decreased serum calcium leads to increase in the duration of plateau phase. That leads to prolongation of the ST segment and thus prolonged QT interval. So when you see this ECG, probably you can relate. Look at the ST segment, which is quite prolonged, right? ST segment is prolonged. Compare this to the previous ECG, where I was barely able to see where is the ST segment, right? T wave is here. So only this portion, maybe very minimal negligible area, I can call it as ST segment. So plateau phase was there, very shortened. But here in this ECG, ST segment appear to be prolonged, and if I calculate the QT interval, it appears to be prolonged. So on this ECG, I have applied the Bezet's formula and have calculated the QT interval, which turned out to be 510 milliseconds. So in a male more than 440 and in a female more than 460, we call it as prolonged QT interval. Here it is 510. So regardless whether this patient is male or female, this will be prolonged. So in hypocalcemia, we have prolonged QT interval, right? So this is the most important MCQ point. In hypercalcemia, we have shortening of the QT interval, and in hypocalcemia, we have prolongation of the QT interval. Okay. Now, the next most important electrolyte which can have a change on the ECG is going to be potassium, right? Because early repolarization, plateau phase, as well as the late repolarization phase, that is phase 1, phase 2, phase 3, we keep effluxing the potassium to the extracellular compartment, right? And then in the phase 4, that is maintaining the resting membrane potential, we keep influxing the potassium from the extracellular compartment. So change in the potassium can affect all these phases. Okay. And literally on the ECG, change in the potassium can affect all components of the ECG. So we will see one by one what happens to the components. So as the potassium levels increase, P wave amplitude decreases. P wave becomes small, amplitude decreases. So P wave has normal height of up to 2.5 small squares. It becomes smaller as the potassium level increases. PR interval starts becoming prolonged. PR interval starts becoming prolonged. QRS complexes become wide. Okay. And the QT interval becomes short. So far we have spoken about two electrolytes, two electrolyte abnormalities. Hypercalcemia was causing short QT and hypocalcemia was causing prolonged QT, right? Hyperkalemia also causes short QT interval. And the most important ECG finding that we get is the T waves. So T waves become tall. So literally what all is happening in the ECG, the P amplitude is becoming decreased, right? P is becoming small. So let us list all these changes. So first thing that is happening is the amplitude of the P is becoming decreased. Then the PR interval, that is becoming prolonged, and then the QRS duration, right? The QRS duration is also becoming prolonged. We will have prolonged QRS duration, or you can say QRS interval. And after that, the most important thing, that is the T wave. What happens to T wave? T wave becomes tall and peaked, right? It becomes tall and peaked, that we have discussed yesterday. So it has a narrow base, right? So this is my T wave. It will have a narrow base. It will be tall. Yesterday we have discussed when do we call it as tall T wave. When it is more than 5 small boxes in limb leads and more than 10 small boxes in the chest leads, we call it as tall. And the third thing is it is peaked or pointed. In case of the acute MI, the T wave will become tall, but it will have broad base and it will have blunted peak, not pointed peak, right? So this is what we call as tall, tented or peaked T waves. So tall, we are going to call it as peaked T waves. It has a point and they are going to be symmetric. So these are the ECG changes that we get in the hyperkalemia. In fact, these changes are progressive. So when the potassium level is in the range of 5.5 to 6.5, see, remember normal potassium is less than 5.5 milliequivalents per liter. So when it starts exceeding 5.5 to 6.5, I can call it as mild hyperkalemia. In mild hyperkalemia, I start seeing the peaked T wave. So you can say peaked T wave is one of the early manifestation of the hyperkalemia. Okay. As the potassium level further increases and goes to 6.5 to 8, we will call it as moderate hyperkalemia. At this point of time, the PR interval, right? This PR interval starts becoming wide. Then the P wave starts becoming short, right? Or stunted or low amplitude P wave. And then the QRS, right? The QRS starts becoming prolonged or wide, and of course the peaked T waves will persist. So that is the second level change that we see when potassium level is 6.5 to 8. So first thing is only T wave become tall. After that, P started becoming short, PR started becoming prolonged, QRS started becoming wide, and the T continues to be tall and peaked. As the potassium level exceeds 8, we will call it as severe hyperkalemia. This is life-threatening because at this time, the P wave which was becoming short, right? Short is gone. P waves are not there. There is loss of P waves. Okay. And now when I look at it, the QRS has become very wide and T is almost as tall as the QRS. So now it looks like what you studied in physics as the sine waves that we used to study in physics. It kind of looks like this, right? That's why it's called a sinusoidal wave or sine wave pattern. This indicates very severe hyperkalemia. Okay. Now this is the ECG which you probably remember from yesterday's class, where you can see the tall peaked T wave, right? Pointed T waves. Then here we can also see the QRS is prolonged. The normal QRS duration. Remember what is the normal QRS duration? The normal QRS duration is less than 120 milliseconds. Means one small square is 40 milliseconds. So normal QRS should be accompanied within 3 small boxes. But when I look here, this is where the QRS begins and this is where it ends. So this is like 1, 2, 3, 4, almost 4.5 small boxes. It is more than 3. So there is prolongation in the QRS duration. And do you see P waves anywhere? The P waves are lost. So here there is loss of P waves, QRS widening, and because there is no visible P waves, I cannot comment about the PR interval, but tall peak T waves are there. And then you can say it is looking like the sine wave pattern, right? It is looking like the sine wave pattern. So I can say that this patient has got very severe hyperkalemia. So this is about the ECG changes in hyperkalemia. Okay. Now what about hypokalemia? It is kind of opposite of it. Whatever we discuss now for hyperkalemia, the opposite of it will be seen in hypokalemia, except one thing, that the QRS complexes become wide even in hypokalemia. That's the only thing that you should be aware of. So when potassium levels decrease, hypokalemia leads to hyperkalemia was making the P wave small, 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 eventually disappearing. Here the P wave will become tall. So P wave will become tall. When do you call it as tall? When the P wave amplitude is more than 0.25 millivolts, which is nothing but more than 2.5 small boxes. And this condition we call it as pseudo P pulmonale. Remember, the tall P waves usually indicate right atrial hypertrophy. That's why we call it as P pulmonale. But this hypokalemia can also cause it, so we call it as pseudo P pulmonale. This is an MCQ that has been asked in the NEET PG. Where do you get pseudo P pulmonale? We get it in patients with hypokalemia. Okay. QRS complexes become wide, but the QT interval in case of hyperkalemia was becoming short, right? So in case of hypokalemia, it becomes prolonged. So you can have prolonged QT interval. Okay. What happens to T waves? T waves in hyperkalemia were becoming tall. So here it will become flattened and eventually it will become inverted. So you can have flattened T waves, or you can have inverted T waves. And last but not the least, the U waves become evident, which are not usually seen in common ECGs, but they become evident here. So that prominent U waves is an important sign of hypokalemia. Whatever MCQs I've asked so far on hypokalemia, it's all about identifying the prominent U waves. Okay, so when I look at this, what do I notice? The QRS is prolonged, then T wave is becoming smaller and smaller. It may become inverted, and then I can have a U wave, a prominent U wave. So if they ask where do you get U wave, the first answer you should mention is hypokalemia. In fact, they build a story around it, saying that here is a patient who presented with decreased intestinal motility, abdominal distension after a long running or like after severe episodes of diarrhea. This patient, or episodes of nausea, vomiting, diarrhea, or acute GE, the patient presented with abdominal distension. The intestinal movements or the intestinal sounds are not heard in this patient, and when ECG is taken, these findings are seen. What does that indicate? So when patient had the acute gastroenteritis, he has lost a lot of potassium through fluid loss. So he has developed hypokalemia, and that hypokalemia is responsible for the U waves, right? That's the understanding of hypokalemia. So hypokalemia kind of understandable from the perspective that if you understand hypokalemia is kind of opposite to it, and extra point to remember here is the presence of prominent U waves, right? Hypercalcemia, what is the point I have to remember? Hypercalcemia shortens the plateau phase and thus shortens the ST segment, thus shortens the QT interval. Hypocalcemia prolongs the plateau phase, so thus prolongs the ST segment and thus prolongs the QT interval, right? With respect to hyper and hypokalemia, mainly concentrate on the T waves and U waves. So T wave becomes tall and peaked in patients with hyperkalemia. The T wave may be normal amplitude or flattened or even inverted, and you can have a prominent U wave in case of hypokalemia. Okay. Why is it called pseudo P pulmonale? P pulmonale basically refers to tall P waves, right? Where do we get the tall P waves? We get when there is right atrial hypertrophy, and that's why it's called as P pulmonale. Why it is called as P pulmonale? Because one of the common causes for right atrial hypertrophy is patient having the problems in the right ventricle or the pulmonary artery, right? Pulmonary hypertension or pulmonary stenosis or concentric right ventricular hypertrophy makes it difficult for the right atrium to fill the blood into it. So it develops, it overworks, it is in the gym, so it develops hypertrophy. It becomes enlarged and dilated, which shows up on the ECG as P pulmonale, as we have discussed in one of the very early videos. So traditionally, if I see a tall P wave, the first thing I should think of is right atrial hypertrophy. But if my patient potassium is low, that may explain. That's why it is called as pseudo P pulmonale. It is tall, but it is not truly because of the right atrial hypertrophy. It is because of hypokalemia. That's why it's called as pseudo P pulmonale. Okay, so that's it about the electrolyte abnormalities. On this topic, I would urge you to go to the QBank of whatever resource you're following, the books or the MedEd app, and solve the questions on the ECG and electrolyte abnormalities, because this is a repeatedly asked template. And I will also be sharing few MCQs on this note, which you can solve. From the next video module onwards, we will start discussing the arrhythmias. It will help if you read essay node action potential before coming to the arrhythmia discussions, because we have to understand arrhythmias conceptually. And as we go through the arrhythmias, I will try to revise the pharmacology and the drugs, antiarrhythmic drugs, their pharmacology also, by relating to the action potential. So read a little bit about the essay node action potential before coming to the next one. So till then, have a good time. I'll see you in the next class.